All right, everyone. Good morning and welcome to another NCLEX review. Today we are going to be finishing up GI and then also getting into musculoskeletal. So now we've reached the point in GI where we're going to be talking about probably the most important disease or condition of GI, which is cirrhosis. So, just a couple of important tips for you to take with you for the NCLEX, and I would write this down if you can. For GI and any system that you're learning for NCLEX, remember, safety is your number one priority. To pass the NCLEX, it's not really about memorizing a whole bunch of symptoms and memorizing a whole bunch of medications. It's about understanding how to keep the patient safe no matter what disease they have. So I'm going to tell you now that the number one issue for safety with a patient with cirrhosis is that they are at risk for bleeding. So everything you're going to do is going to be to prevent them from bleeding depending on where they're bleeding from. Okay? So that's some very important knowledge for you to remember and understand. For NCLEX, it's not about, oh my gosh, I have to memorize 100,000 medications and know what each one does and know each symptom. No, there are some basic medications you have to know what they do and you have to know who not to give them to, right? That's a given. But the major focus of NCLEX is, can you keep patients safe? Cirrhosis, your patient is at risk for bleeding. So what is cirrhosis? Cirrhosis is a chronic destruction of liver cells. Cirrhosis is a permanent scarring of the liver. Okay, so let me show you a picture. And bear with me, I'm having some technical difficulties. Okay, so this is an example here on the left of a healthy liver. The liver should be very smooth. But as we can see here with cirrhosis, we have some scarring of the tissue, and this is permanent. And this represents the cells, which are called hepatocytes of the liver, have been permanently damaged. And so they're not performing their function properly. So you have to ask yourself, well, what is the function of the liver? Okay, so write this down. The kidneys are like filters, right? The kidneys, have you ever used a Brita filter before? Remember the Brita filter? It's like the plastic pitcher you would buy and you put water in and the water goes through the filter and comes out, like a little more purified or clean, right? So your kidneys are like filters, right? The liver is a detoxifier. So the liver can take a toxic chemical and turn it into something harmless. Does that make sense? So whereas your liver is kind of like a colander or a sieve, You know, like a colander when you're making spaghetti and you pour the water in the spaghetti and the colander just catches the spaghetti, like a passoa, right? Your kidneys are like that. But the liver is a detoxifier, okay? So the liver has over 600 functions. 600 functions. You cannot live without your liver. Okay, your liver makes your clotting factor so that you don't bleed to death. Your liver makes bile so that you can digest fats. Your liver stores glycogen so that you have a energy reserve, okay? So that when you run out of glucose for energy in your blood, all the excess glucose that you don't need in your blood gets stored in the liver as glycogen. And when you begin moving around, performing activities, exercising, and you need energy, one of the first energy sources your body will tap into is that glycogen. So the liver is responsible for that. Like I said, the liver is responsible for detoxifying all of these harmful chemicals that could hurt you, like ammonia, okay? And it will turn it into something harmless that can then leave the body. So when you look at cirrhosis, the function of the liver declines as more and more liver cells become damaged and permanently destroyed through this scarring. Less and less of the liver is able to perform its function, and the individual will begin to have manifestations of this liver failure. So, what are some causes of cirrhosis? Alcoholism. Alcohol, write this down. Alcohol is an outright poison to the body. You might as well drink bleach. I think you would be better off drinking bleach than alcohol. Alcohol does nothing positive for your body. I know there's some studies, oh, if you drink one glass of red wine, it can help decrease heart disease. No, whatever. Alcohol is a poison, and the moment it enters your body is panicking, trying to send it to the liver to detoxify it, to get it out of the body. It is a threat, a burden, and an insult to the body. So chronic alcohol abuse damages the liver because it is a poison to the liver. It is a burden to the liver. Hepatitis C can damage the liver. So I always think of hepatitis C and I always think of hepatitis cirrhosis. So hepatitis C, left untreated, can lead to cirrhosis. Non-fatty liver disease and non-alcoholic steatohepatitis. So non-alcoholic fatty liver disease, break it down. They have a fatty liver, but it's not because of alcohol. So one of the ways to describe a damaged liver is you can say the liver is fatty. So if you ever hear a doctor say a fatty liver, that liver has begun to undergo progressive damage. And the person needs to make lifestyle changes because if they don't, they will develop cirrhosis. And cirrhosis is irreversible. And cirrhosis can lead to death and liver cancer. Then we have steatohepatitis. So these non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, again, it's important to understand it's not because of alcohol. It is usually because of obesity and a high-fat diet. Stop eating all that fried food every day. Stop eating fried chicken and grill and banan peze, and stop eating food you cooked in a whole bunch of oil. Okay. The more natural the food, the better. That means if you didn't have to cook it in oil, the better it is for your body. Use an air fryer, bake it, okay? Steam it. Because years and years of poor diet and a high fatty diet is what leads to fatty liver. And fatty liver leads to cirrhosis. And remember, cirrhosis leads to liver failure, death, liver cancer. So, what are the complications of cirrhosis that you should understand for NCLEX? Because remember, NCLEX is all about can you keep this patient safe? So, for cirrhosis, you have to know well, what are you keeping them safe from? What is the problem? So, the number one problem here is that remember, your liver makes your clotting factors. Write that down. The liver makes the clotting factors. So someone with cirrhosis, their liver's not working right. So they don't make enough clotting factors. So when they bleed, they don't have enough clotting factors to stop the bleeding. So they can bleed out very easily. They can bruise very easily. So write this down. Cirrhosis, number one priority. The patient is at risk for bleeding. What are you going to check? Platelet level, PT, and INR. That's how you're going to keep track of it because it's not just about, oh my gosh, I have to protect the patient from bleeding. It's let me monitor them along the way to see how at risk they are, right? So that if the platelets are low and the PT INR is high, you know they are at risk for bleeding. PT and INR is time. PT and INR is time. PT and INR is how long does it take the blood to clot? Someone with cirrhosis doesn't make enough clotting factors, so it's going to take their blood a long time to clot, so their PT and INR will be high. Okay? Assessment of the patient will bruise easily and they will bleed easily. Treatment. So if their platelets are low, we will probably have to give them a platelet transfusion. Also, we can give them vitamin K because that will help with their clotting factors. So I always think of vitamin K as vitamin clot. That's how I always think of it. It makes the blood clot. Okay? So another problem is jaundice. Jaundice occurs because the liver is unable to metabolize bilirubin. So bilirubin is the waste product from old damaged red blood cells. So unfortunately, there's really nothing you can do about the jaundice as a nurse. In taking care of the liver, we can help to reduce it, but at a certain point in cirrhosis, there's nothing we can do about it. And it's just a sign that the liver is damaged. But let's say the person has liver damage because of acute Tylenol overdose. If we, stop the Tylenol and give the antidote, which is acetylcysteine, that can help reduce the jaundice. If a newborn baby is jaundiced, which is common, and we're going to talk about that because a newborn's liver is severely immature, and jaundice because of bilirubinemia is very common in the newborn. They put them under the lights with the special little goggles. So there are examples of when we can treat jaundice. But if the jaundice is because of cirrhosis, the liver is so damaged, there's usually nothing you can do as a nurse about it. And it's not really a safety issue. It's more of a psychological, because of a change in body image issue. So the skin and the sclera, which is the white part of the eyes, can turn yellow. So that's something to be aware of, and it's something to educate the patient. You know, the patient might feel anxious and say, well, what can we do to reverse this? And after speaking with the healthcare provider, if there's nothing we could do to reverse it, you can educate the patient. Well, your skin is yellow because your liver's not breaking down a substance called bilirubin. Okay, so sometimes educating the patient can help them to just understand more about what's going on, because most of the time understanding can help to reduce anxiety, because we're often anxious about what we don't understand. Another major issue is portal hypertension. So make sure you know this well. So the portal vein drains blood from the intestines to the liver. So someone with cirrhosis is going to have a congestion, a backup in this portal vein. And this congestion is going to lead to an increased pressure inside that portal vein, which can lead to something called portal hypertension. So portal hypertension is a result or consequence of liver congestion, because the liver is not working well. It's not able to receive and send out substances the way that it should. So portal hypertension is going to lead to many problems. Portal hypertension is going to lead to ascites, which is a buildup of fluid in the abdomen. It can lead to GI bleed. It can lead to encephalopathy, and it can lead to low platelets. So we're going to learn about each of these as we continue on. But ascites, we're going to learn about that next. GI bleed. We're going to learn about this in just a bit, and I've got a picture for you, okay? So just hang tight. All right, so we said that portal hypertension and just the disease process of cirrhosis can lead to ascites. Ascites is an accumulation of fluid in the peritoneal cavity due to venous congestion. So remember, the portal vein, it drains blood. And you know, it's something, everything ties in together. We're going to talk, oh my gosh, everything ties in together. But anyways, remember, the portal vein drains blood from the intestines and sends it to the liver. But we just established that the liver is going to be congested because of the decreased liver function, right? And so it's going to send the fluid right back. Now, the issue is, write this down, your liver makes an invaluable amount of proteins for your body. Write this down, one of the proteins that your liver makes is called albumin. Albumin. And I want you to think of albumin as Officer Al. Write this down. Albumin. And here's a tip. Anytime something ends in 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 the body, albumin, hemoglobin, it's usually a protein, okay? So albumin is a protein that maintains something called oncotic pressure, okay? What does that mean in English? It tells your fluid where to go, okay? In simple terms, albumin keeps fluid inside the intravascular space. What does that mean? It keeps fluid inside the blood vessels. Write that down. Albumin keeps fluid inside the blood vessels. So by keeping fluid inside the blood vessels, it maintains a pressure inside of the vessels. Write in the chat and let me know if that makes sense. So I see there's another gene on here. I know, is that gene Sant? Let me know in the chat. Okay, so very good. So everyone's following along. Let me know somebody's named Jean in the participants. Let me know if this is Jean Sant. Ceant. Let me know. All right. So the way that I remember this is I think of albumin as Officer Al. And he works traffic police. He's a traffic officer. And it's like he has like a stop sign and he's like at the edge of the blood vessels, like, and he's like telling the fluid, no, you stay in here, right? And he's working to keep fluid inside the blood vessel. Okay, so who makes albumin? The liver. Or what makes albumin? The liver. So I want you to let me know in the chat. Oh, good. Oh my gosh, I've missed you so much. I know you don't miss a lot of class, but I don't know why. I thought of you so many times. I'm like, I really miss him. I'm so happy to see you. You are wonderful. All of you are wonderful. I'm so thankful for all of my students. All right. So the liver makes albumin. So I want you to let me know in the chat. If the liver makes albumin, what do you think is going to happen to the amount of albumin in the body in somebody with cirrhosis? Think about it. If the liver makes albumin and someone with cirrhosis has a damaged liver, what do you think is going to be a result? Yes, someone with cirrhosis will have low albumin. So write that down. Someone with cirrhosis will have a low albumin. So we're already establishing some very important lab levels here, right? So write down lab levels for cirrhosis. Platelets are going to be low, right? PT-INR is going to be high. Albumin is going to be low. What about the ALT-AST? What do you think is going to happen? ALT-AST, those are your liver enzymes. They are going to be high. Excellent work. Excellent. You're going to pass. You're going to pass the NCLEX. Excellent. Okay. So write that down. Lab levels for cirrhosis. Platelets are going to be low. Right? PT-INR is going to be high. Albumin is going to be low because the liver is not making enough of it. Right? ALT-AST is going to be high because those are signs of liver damage. So back to albumin. we've established some very important principles about albumin. Albumin maintains the oncotic pressure. It keeps fluid inside the blood vessel so that fluid doesn't leak out. In someone with cirrhosis, they don't make enough albumin. So what do you think is going to happen to the fluid inside their blood vessels? Do you think the fluid's going to stay inside, or do you think it's going to leak out? It's going to leak out. That's what you're seeing here in this picture. In an individual with cirrhosis is at risk for ascites because of hypoalbuminemia, hypoalbuminemia. They have low albumin. So there's not enough officer Al. There's not enough officer Al to tell the fluid, you stay inside the blood vessel. No, there's no officer Al there, so the fluid leaks out. That congestion, that fluid from the portal vein that can't get through to the liver is going to come back and leak out. And so the assessment of ascites is an enlarged or protruding abdomen. It's like the patient looks pregnant. So let me show you a picture. And when I show you this picture, I want you to tell me what you think the major issue is going to be for this patient. I want you to think like a nurse, and I want you to think like a nurse who puts safety first. Tell me in the chat, what's going to be the major issue with this patient? All right, so let me know in the chat. Very good. Okay, somebody already put it. Yes. So somebody with cirrhosis that has caused ascites, or someone with ascites, period, they are going to have respiratory distress. So write that down. Number one issue with ascites is respiratory distress. That is your number one concern, okay? So your number one focus for ascites is it can make breathing difficult. So your number one priority for ascites is to monitor breathing. So that would be one of your priorities. Like remember, airway, breathing, circulation. So ascites would be a breathing problem. Let me know in the chat if that makes sense. All right, very good. So let's see where we're headed here. Okay. Let's talk about treatment for ascites. So we can see this looks very uncomfortable. Do you want your patient to be laying flat if they're in respiratory distress, or would you want that to be ideal for them to be like most of the time, like, oh, let's just lay this patient flat? No, right? We would want to put them like semi-fowlers to promote ventilation. Like semi-fowlers high fowlers, check their O2 saturation, keep a track of their respiratory rate and O2 saturation so that if we need to give them oxygen and set them even higher, we can do that. I know this next picture is a little confusing, but he has a pillow under his head. So abdominal paracentesis is the major treatment. We could do diuretics too, right? Diuretics would get that fluid and send it to the kidneys so he can pee it out, which would be awesome. And then like a more physical intervention would be a paracentesis. And remember, anytime something ends with the word centesis, we're aspirating fluid. And so paracentesis can be done laying down, it can be done sitting up. And what's important is we want to weigh the patient before and after. And we're going to measure the amount of fluid. And then keep in mind that the blood pressure could drop. So write this down. People with cirrhosis are already at risk for low blood pressure. And I know it's confusing because we said that they have portal hypertension, but believe it or not, portal hypertension does not cause systemic hypertension. So write that down as well. Portal hypertension does not cause systemic hypertension. If anything, cirrhosis can lead to low blood pressure, low systemic blood pressure. Okay, it's actually one of the major signs that cirrhosis is getting really bad. Okay, is when the person's systemic blood pressure is low. So after a paracentesis, the patient is also at risk for low blood pressure because we're rapidly removing fluid from the body. And that shift of fluid so rapidly, we don't want them to stand up quickly. They could feel very dizzy. So afterwards, it would be better if the patient can rest, like semi-fowlers, and we monitor their vitals, especially their blood pressure, and also keep a track of their respiratory status because the needle could puncture something. For example, it could puncture a lung and we would see more respiratory distress. So just keep track of their respiratory status, their blood pressure, and also just their overall status for any signs of inadvertent puncture. Okay? So let's see where we are. Also, we would want to, so let me just go back to the study guide. Hold on. So for ascites, we would want to measure abdominal girth, usually daily. And so we wrap the measuring tape around the level of the umbilicus. And we could put markings on the side of where the tape measure is going to be measured, so that we're always measuring at the same location. And we do this daily to see if it's getting better or worse. Sodium restriction, fluid restriction is ordered, diuretics, and paracentesis. All right. Next up is esophageal varices. So this, guys, NCLEX, you have to know that a patient with cirrhosis is at risk for GI bleed. 100%. So remember we talked about portal hypertension, that portal vein that drains blood from the intestines trying to bring it to the liver, but unfortunately, and I know I get off topic a lot, but I'm just going to say, well, it's just when you're explaining it and you see how everything ties together, it's eye-opening. But I'm going to try my best to shut up and stay on topic because I want just to show you for NCLEX and get you to pass the NCLEX. But anyways, all right. So remember, we talked about the portal vein. It's trying to bring the blood from the small intestines to the liver. Someone with cirrhosis, their liver's not working well, and there's liver congestion, like a backup. So the blood from the portal vein, it has to back up to somewhere. So unfortunately, it can back up into the veins of the esophagus, and that congestion, it can make the veins of the esophagus extremely fragile, and they can rupture. So let's look at some pictures. So here is a layout of the hepatic portal vein, and as we can see, it's connected to the veins of the GI tract. Okay. Portal hypertension leads to esophageal varices. Okay, so here is our esophagus, and here are the veins of the esophagus. Okay, and as we can see, the portal vein, and here would be the liver, right? The portal vein, it is connected to the veins of the esophagus. And so here we have in this picture, we have a cirrhotic liver, and let me just make this a little bigger. So here we have a cirrhotic liver, okay? Here we have the portal vein, very congested, and it's going to cause a backup of the congestion to the veins of the esophagus. And so what we have here is if we were to put a camera down the patient's mouth and into the esophagus, if we were looking down, look at this picture up here. This is what we would see. We would see these swollen, engorged veins. And when they look very twisted like that, they call it tortuous. It looks very tortuous and engorged. And they're veins, so they're filled with blood. And they're fragile because they're so engorged with blood that's not really supposed to be sitting there that long. And so they can rupture, and then you're going to have outright bleeding straight into the esophagus and stomach and intestine. So you're going to have GI bleed. Let me know in the chat if that makes sense. So here we have different variations, degrees of severity. Okay, as we can see here, picture C is severe. This doesn't even look like an esophagus. Okay, this doesn't, right? The esophagus is supposed to be like a smooth lining, a smooth lumen, right? Just a tube. Even this, you see the esophageal varices here, that's not normal. The esophagus is supposed to be a smooth tube. So this is abnormal. This is abnormal. This is, and so here we have a perforation of one of the esophageal varices, and we have outright GI bleed that is going to lead to hypovolemia and death if we do not address this. So this would be an emergency EGD, an emergency upper GI endoscopy, where the endoscopist will cauterize. He will locate the bleed and burn it shut. Okay, so the number one priority for esophageal varices is to understand the risk of rupture and GI bleed. All right, back to the study guide. So esophageal varices leads to GI bleed, which can lead to hemorrhage and shock and death. So look for hematemesis where they're vomiting blood. Look for melena. Can you tell me, why would somebody with esophageal varices, why would you expect to see black poop instead of bright red poop? Upper, very good. But explain the rationale. Why would you expect to see black poop if you're like, okay, you're getting a report, I'm giving you a patient in the ICU, and I'm like, this patient has cirrhosis and end stage liver failure, and they have esophageal varices, and they have an acute GI bleed. The stools are coming out black and tarry. But why are they black? Why are they not red? Explain that to me. We talked about that last lecture. Tell me in the chat. So think about, let me show you a picture because nobody's answering me. Okay, so let's go back to this picture. So this is the esophagus, right? Upper GI. So this is an upper GI bleed. So this blood is going to pass through the stomach and the intestines and get digested. So that's why the poop is going to come out black because the blood gets digested. If this bleeding happened in the lower GI, like after the stomach, then it would be red. You see? So the poop is going to come out black because the blood is coming from the upper GI and it's going to get digested. So when we're looking for signs of esophageal varices, look for vomiting of blood and the blood would be red. Look for black poop because it's upper GI bleed. And signs of shock, low blood pressure, high heart rate. And treatment, we already said, is endoscopy to find the bleed and cauterize it. Other things that we're looking for, or manifestations, hepatic encephalopathy. So the liver cannot detoxify ammonia, and it leads to a buildup of ammonia, which can lead to brain damage. So hepatic encephalopathy. Hepatic means liver, encephalo means head or brain, and opathy means a disorder of. So encephalopathy is a disorder of the brain, and hepatic means because of the liver. So this is very major manifestation of cirrhosis, and you're going to have to know how to treat this. So first you have to know how to spot it. So altered mental status, confusion, and forgetfulness. So if a patient with cirrhosis develops altered mental status, that is usually because of ammonia buildup. So the way we treat that is we give them lactulose. Lactulose is going to remove the excess ammonia and it's going to cause diarrhea. Also keep in mind that liver failure can cause the kidneys to shut down. That's called hepatorenal syndrome. Some other findings in cirrhosis. So let me show you. So let me share this screen. So we talked about jaundice, a yellowing of the sclera in the skin. Also, have you ever heard of Medusa? Medusa is this legend, okay? I hope she's not real because that's terrifying. But she was a very beautiful woman, and a man raped her. And long story short, her hair is made out of snakes. This is like a Haitian nightmare, right? Because Haitian people, we hate snakes. Well, this lady, her hair is made out of snakes. And if she looks at a man, if a man looks at her in her eyes, she can turn that man into stone, like make his whole body become a rock, a statue. So that is like the payback for that man raping her. And he raped her because she was so beautiful. And so Caput medusae is named after her. Somebody with cirrhosis, the veins become so enlarged and engorged, they look like snakes, so they look like her hair, basically. Okay, I don't know how that got out of order, but all right. So that's caput medusae. Then we have asterixis. So this is going to show you asterixis. It's a tremor, like a flapping tremor of the hands. So that's also a sign of cirrhosis. Okay. All right. Let me put this slide up. So go ahead and write this down or take a picture. These are the lab levels. All right. So go ahead and take a few minutes and write this down, and then we'll talk about it. You have to know this for NCLEX. All right, so let's talk about these important labs that you need to know and just understand like what they mean. Okay, I didn't say memorize any levels. NCLEX is going to give you the levels. You just have to understand what the trend or the pattern means. So ALT, AST tell you how your liver's doing. Amylase and lipase are going to tell you how the pancreas is doing. So if they're elevated, that indicates pancreatitis. So liver damage, high ALT, AST, high bilirubin, high PT, and high INR, and high ammonia. And so the only thing that's going to be low really is the platelets. And but we talked about that already. Also, we talked about, we said high albumin. Okay. All right. So that is that. So let's see. Let's do some questions on cirrhosis to just make sure you understand. And then we're going to talk about medications for GI. Then we'll take a little break and then we'll do musculoskeletal. And musculoskeletal is so simple and to the point. We will breeze through that. Just give me a moment to get the questions up. And some of these questions, again, are learning questions where we may not have gone over it, but we'll learn it because we're doing the question. Just a way to save time. All right. Question 46. A client with cirrhosis is receiving lactulose. During the assessment, the nurse notes increased confusion in asterixis. The nurse should please put your answers in the chat for question 46. Very good. The correct answer for 46 is 1. So this is a really tricky one. It's a very tricky question. So clients with cirrhosis can develop hepatic encephalopathy caused by increased ammonia levels. So we're giving them the lactulose because of the confusion. They're confused because their ammonia is up. So if we hold the lactulose, their confusion will get worse. Okay? So GI bleed. So let me see. GI bleeding and protein consumed in the diet increase protein in the intestine and can elevate ammonia levels. So we're going to assess the patient for GI bleeding. And I know that sounds silly because it's very easy to assess the patient for GI bleeding. Are they vomiting blood? Do they have the black tarry stools, right? But that is the correct answer. Okay. Next up, we're going to do 47. The nurse is assessing a client with cirrhosis who has developed hepatic encephalopathy. The nurse should notify the physician of a decrease in which serum lab value that is a potential precipitating factor for hepatic encephalopathy. This is another tricky one. This is a tricky question. I'm so sorry, guys. This question is not even fair. That's how tricky it is. But the correct answer is 3 potassium. So hypokalemia is a precipitating factor in hepatic encephalopathy. So when the potassium drops, it can mean that hepatic encephalopathy is getting worse. Okay, let me see. 48. A client has advanced cirrhosis of the liver. The client's spouse asks the nurse why his abdomen is swollen, making it very difficult for him to fasten his pants. How should the nurse respond to provide the most accurate explanation of the disease process? Now, this is a good question. Mm-hmm. Yep. Absolutely. This is a beautiful question. It's very similar to, NCLEX. So portal hypertension and hypoalbuminemia as a result of cirrhosis can cause a fluid shift into the peritoneal space, causing ascites. Very good. All right, let's see what the next question is. A client with cirrhosis begins to develop ascites. Spironolactone aldactone is prescribed to treat the ascites. What type of medication is spironolactone? Somebody tell me in the chat. Oh, 47. 47, the correct answer was 3, potassium. Oh my gosh, what first one? Okay, 51. Somebody tell me in the chat. We're on question 51 now. What type of medication is spironolactone? It's a potassium sparing what? Is it a pain medication? Is it a blood pressure medication? Is it what? It's a diuretic. Very good. So a client with cirrhosis begins to develop ascites. Spironolactone is prescribed to treat the ascites. The nurse should monitor the client closely for which of the following drug-related adverse effects. What is the correct answer for 51?
The, photog- the photographer Marcus.
Very good. Very good. I love this question. This is NCLEX right here. Like this is the level of NCLEX. This is, I mean, NCLEX might have questions just a little more complicated, but this is the level of NCLEX right here. So if you got this question right, this is what you can expect on NCLEX. Very straightforward. And it's understanding, can you keep the patient safe? Because potassium imbalances are very dangerous because they can be deadly. They could lead to cardiac issues. That's a safety issue. So do you see where NCLEX is coming? It's not like, oh, can you remember this one random fact that only affects 3% of the population? No, this is a major safety issue when you're giving this medication, right? So whenever you're learning about a medication, all you have to understand is what could kill the patient if I don't watch this. Okay, very good. Very, very good. Okay, next we're going to do 55. The nurse is reviewing the chart information for a client with increased ascites. The data includes the following: temperature 37.2, heart rate 118, shallow respirations of 26, BP of 128 over 76, and O2 saturation 89% on room air. Which action should receive priority by the nurse? Assess the heart sounds, obtain a prescription for blood cultures, prepare for a paracentesis, raise the head of the bed. Very good. The correct answer is 4. So obviously they're having issues breathing because the ascites, remember ascites causes respiratory distress. So we're going to raise the head of the bed, and then I know that putting them on oxygen isn't one of the choices, but because the O2 sat is low, we would then put them on oxygen, right? Very good. All right, next up is 56. Which of the following positions would be appropriate for a client with severe ascites? Very good. Fowlers. Very good. So we want to promote proper ventilation. So sitting them up like, 60 degrees is good. All right. And last question, and then we're going to take a break and go to um, we'll do the meds, and then we'll do musculoskeletal is 61. All right, a client's serum ammonia level is elevated and the physician prescribes 30 mLs of lactulose. Which of the following is an adverse effect of this drug? Mm-hmm. Because somebody said two, but two, tell me, is two a good thing or a bad thing if they have an improved level of consciousness? Yeah, that's a good thing, but this question is asking for adverse effect. Adverse effect is a bad thing, right? So, because somebody said number two, no, because if their ammonia level is elevated, that's what's going to make them confused, like the hepatic encephalopathy. So if it's asking for an adverse effect, we would not say improved level of consciousness because that's not an adverse effect. That's a good thing. So the correct answer is 3 because we even on the study guide it says lactulose causes diarrhea. Okay. All right. So now let's go back to the study guide. And so here, next to hepatic encephalopathy, lactulose, it will remove excess ammonia and it causes diarrhea. So that's, increased bowel movement. So I'm telling you, the students I've had that have passed the NCLEX, and I never really have kept track of how many, but I'm very thankful for each one. And I'm very proud of each one. But all of them come back and tell me that what they read in the study guide and learned in the class, that's what helped them to pass. So this is just another example of what's in the study guide helps you to answer questions correctly. All right. Now we're going to go to some medications, which starts on page 229. All right, guys. So let's take a 5-minute break and we'll come back at 11:25 and go over these medications. Thank you. All right, so GI medications. So you've got your antacids. So they react with gastric acid to produce neutral salts or salts of low acidity. So basically, they work against the acid in the stomach to try to like neutralize it or reduce the acidity. So they're very useful in peptic ulcer disease and people with GERD. So some very popular examples are like Tums, Alka-Seltzer, Maalox, Mylanta. So nursing consideration, you don't want to give them with other medications. So you want to give them an hour apart from other medications to avoid interaction. So that's my NCLEX tip for antacids. Next up is sucralfate, also called carafate. Um, this also is a very important one. It's like a liquid, and every time I've given it, it was pink, but it doesn't have to be pink. But when you drink it, it creates a protective barrier. That thick liquid, it lines the stomach, and it's very useful for patients with ulcers. So someone with peptic ulcer disease, this is very helpful. But what's very important is you have to take it on an empty stomach. The stomach has to be empty so that the medication can line the stomach. So that's my tip for NCLEX on that one. So antacids, give them an hour apart from other medications. Sucralfate, you have to take it on an empty stomach. Proton pump inhibitors, there's nothing really crazy you have to know about them, but just know, pantoprazole and omeprazole, um, they suppress gastric secretion of acid. So, they're very helpful again in people with ulcers and GERD. Next up is your bile acid sequestrants like cholestyramine. So they're used to treat biliary obstruction and high cholesterol. I would just know that they cause constipation. So you're probably going to have to give them with stool softeners. Lactulose we've talked about already. They're used for high ammonia levels in the blood with people with hepatic encephalopathy. Just make sure you know they cause diarrhea. They increase peristalsis, movement, through the GI tract, and they increase evacuation of the bowels. So, antiemetics. So these are used to control nausea and vomiting and motion sickness. So like ondansetron, Zofran. So another one that I would know is prochlorperazine or compazine. You don't give them to the elderly. Okay. Laxatives, they're used to cause poop. So docusate sodium, senna, magnesium citrate, bisacodyl. So make sure you know that if you're giving a patient a laxative, that you just want to make sure that they're not dehydrated. So you want to make sure that they're getting enough fluid in. And also, anytime a patient, we're giving them laxatives or anything, we also want to make sure their electrolytes are in balance. So making sure fluid and electrolytes are balanced, that they have enough fluid coming in, monitor their output, and monitor their basic electrolytes like potassium and magnesium. Medications that control diarrhea, believe it or not, we don't really stop diarrhea. We really don't as nurses. So loperamide, which is Imodium, that would stop diarrhea. I've only given that once in 13, 14 years of being a nurse because most of the time healthcare providers believe that diarrhea is the body's way of getting rid of something that it needs to, like a toxin or something. But sometimes diarrhea could be due to, you know, I don't know, some type of acid base imbalance or electrolyte issues or something. So they would rather identify the cause of the diarrhea and treat the cause so that the diarrhea stops. But they don't want to stop the diarrhea because that's not fixing what's causing it. So it's either because of some type of fluid and electrolyte imbalance, it can be due to a toxin. So if it's because of fluids, we replace the fluids. If it's because of electrolytes, we check the electrolytes and replace them as needed. If it's because of some type of toxin, we want to identify it, and we can do that with a stool culture. For example, if it's C. diff, then they will do stool culture and then choose the correct antibiotic and go from there. So that's GI, guys. Congratulations, you made it through. So now we're going to be heading over to the world of musculoskeletal and ortho. So we're going to be on page 233. So let's go ahead and let's take another 5-minute break. And then when we come back, we're going to do musculoskeletal, which officially starts on page 235. And we will, I'm not going to overwhelm you, because again, you still have a lot to memorize with cirrhosis. So we're going to just get a good amount of musculoskeletal done, and then so that way you can focus on studying cirrhosis in your GI meds and whatever we learn on musculoskeletal today. So see you in 5 minutes. Okay, let me. All right, so we are on page 235. So, musculoskeletal anatomy and physiology. So, your skeleton has two main parts, but first, we're going to talk about musculoskeletal. So, it includes your muscular system and your skeletal system and how they work together. So, you need your skeletal system for structure and support, because if it wasn't for your skeleton, your organs would just be kind of like all in a plastic bag, right? Whereas because of the skull, your brain has a safe vault to sit in, and your lungs are well protected by your ribs, and your reproductive organs are protected by your pelvis, and your bones. Not only do they provide structure and support and protection, but they also provide a framework so that your muscles can attach onto them. And as you move and leverage your body and pivot your body, your muscles are able to extend and contract so that you can move. So, and if it wasn't for your bones, your muscles wouldn't have something to stick to attach to. So, the skeleton has two main parts. You have your axial skeleton and your appendicular skeleton. So the axial skeleton is the center, and the appendicular are your appendages or your extremities. So the axial is your cranium, your vertebrae, and your ribs, and the appendicular portion are your limbs, your shoulders, and your hips. So you have two main cells of the musculoskeletal system, osteoblasts and osteoclasts. So the B in blast, I want you to think build up. So osteoblasts build bone up and osteoclasts destroy them. Okay. Next up is the characteristics of bone. So, bones support and protect structures of the body. They provide attachments for muscles, tendons, and ligaments. And they contain tissues in the central cavities, such as bone marrow, which aid in the formation of blood cells. Also, bones assist in regulating calcium and phosphate levels. Bone growth. So bones grow by length and by width. So bone growth by length is due to epiphyseal plates or growth plates, which are located at the ends of the long bones. So here we have the epiphyseal line, and they are made up of cartilage located at the metaphysis of long bones, and they are the last portion of the bones to harden. So once they fuse, the bones stop growing in length, and this occurs between the ages of 15 and 24. So that's usually when individuals experience a growth spurt, and once the epiphyseal plates harden, the bones will stop growing in length, and so the person will stop growing in height. Width of the bone is due to osteoblasts. As aging occurs, bone reabsorption accelerates, decreasing bone mass and predisposing the person to injury. So, as we get older, our bone mass decreases. And so, that's where we're more at risk for fractures when we fall the older we get. An injury to a bone is called a fracture. Next up, we're going to learn what is a joint. A joint is where two bones meet. Joints are very important for movement. Excuse me. Okay, so joints are covered with cartilage. Joint cavities are called synovial cavities, and they are filled with synovial fluid that allow for smooth movement of the joint. The synovial fluid also lubricates the cartilage and absorbs shock. So if somebody has an infection of the synovial cavity or the synovial fluid, that is called synovitis. Next up is muscle. Muscles are very important for movement. So hang on. Muscle. So muscles are very important for movement, and they are made up of bundles of muscle fibers arranged into fascicles. So guys, give me one moment. Thank you so much. All right, so muscles are made up of muscle fibers arranged into fascicles, and they also have blood vessels that bring oxygen to the muscle bundles. So, types of muscle, you have three major types. You have smooth muscle, cardiac muscle, and skeletal muscle. So, smooth muscle is involuntary. You cannot control smooth muscle, and this is what lines your intestines. This is what helps to push food through the GI tract for peristalsis. And this is also what's around the bronchioles. Remember, we talked about bronchial constriction and bronchodilation. This is that muscle that wraps around the bronchioles, so you cannot control it, thank God, right? You don't want to have to think about that. Cardiac muscle is also involuntary, thank God. You don't have to worry about your heart beating, it's just going to do it on its own. And so that's what helps your heart to contract and relax. That skeletal muscle, which is what we're learning about today for musculoskeletal, this is voluntary. You have control over the movement of your skeletal muscle. So you have control over getting up and going to the bathroom, sitting down. So muscle is attached to the bones by structures called tendons. Okay. So we're going to learn the difference between a tendon and a muscle. So tendons attach a muscle to bone, and they're very important for movement. Injury to a tendon is called a strain. So just think a strain has a T in it, so that's damage to a tendon. So a strain is often caused by overstretching a muscle. So for example, the hamstring muscle. So as we can see, a tendon connects a muscle to a bone. So a tendon is this this silvery band. Okay. So oftentimes when you're cleaning meat, when you're cleaning chicken, like let's say for example the drumstick, and you are disconnecting the meat from the bone, you're cutting through a tendon. Okay. But let's say you are separating the drumstick from the thigh muscle of the meat, and you have to cut between those two bones. You are cutting through ligaments because ligaments connect one bone to another bone. Okay, so here's a tendon, this silvery band here that's connecting the muscle to the bone. And here is ligament, bone to bone. So when we have an injury to a ligament, we call that a sprain. So an injury to a tendon has a T in it, strain. Injury to a ligament, sprain. Okay, so we saw the picture of a strain already. Okay, and then here is a sprain. So usually it's when the ligament is torn or overstretched, like when you step wrong and you sprain an ankle. All right. Diagnostic tests, you can read this for homework, okay? Just know that a bone scan is used to diagnose cancer. All right, so we already spoke about musculoskeletal injuries, strains, and sprains. For both, you want to use a treatment method called RICE. Okay, so for both strains and sprains, I want you to know RICE: rest, ice, compression, elevation. So when we have a musculoskeletal injury, most of the time the healthcare provider is going to recommend the patient to do RICE. You want to rest the area because you want to prevent further damage. If something is already damaged and if you keep stepping on it, if you keep walking on it or keep using it, you're probably going to injure it worse or make it worse. So that's why you want to rest the area to allow it to heal and prevent further damage. You want to use I for ice, which is going to cause vasoconstriction and reduce edema. So anytime there's trauma or injury to an area, the body's going to want to flood the area with white blood cells. And how do white blood cells travel? In the blood. Okay, so when there's an injury, it's going to cause increased blood flow to the area, and that increased blood flow is going to cause edema, and edema is going to cause swelling, which is going to be painful. So we use ice because ice causes vasoconstriction and it's going to reduce that painful swelling. Compression can also reduce that swelling. Elevation can also reduce swelling. And we want to alternate between ice and heat. The ice is going to reduce the swelling. The heat is going to relax the muscle. All right, next up, we're going to learn about different types of fractures. And then that's going to be it for today because I don't want to just overwhelm you with a lot of information. All right, so a fracture is a break in the continuity of the bone, and it can be caused by trauma, twisting as a result of muscle spasm, an indirect loss of leverage, bone decalcification, or it can be caused because of a disease like a pathological fracture, like bone cancer, for example, multiple myeloma. So different types of fractures. So first up, we have a simple or closed fracture. This is the bone is broken, but the skin is intact. The skin over the fracture is intact. This is a simple or closed fracture. Next up, we have a comminuted fracture. A comminuted fracture is the bone is crushed up into numerous fragments, many little pieces. Next up, we have a complete fracture. A complete fracture means that the bone is separated into two complete parts. Next up is compression fracture, which is a fractured bone is compressed by another bone. So let's say, God forbid, the patient fell on their butt and this vertebrae and this vertebrae pushed against this middle one and caused this compression fracture. A depressed fracture is when the bone fragments are driven inwards. Green stick fracture, one side of the bone is broken and the other is bent. So this is most common in children, especially when they're first learning to walk, like toddlers, and they fall and they put their hand out to catch the fall and they break. And the bone breaks and the other side is bent. So we can see one side is broken here and the other side is bent. Impacted fracture, a part of the fractured bone is driven into another bone. Next up, we have incomplete fracture, where the fractured line doesn't extend through the full bone. It's like it didn't break clean across. There's still a little, like if you can see, it's really hard to see, but here, this side, it's not broken all the way. It didn't break clean through. It's not a complete fracture, right? So a complete fracture, it broke into two complete, look, hold on. A complete fracture, it broke into two clean pieces. Incomplete, it didn't. And then if it broke into many pieces, it's comminuted, right? Then we have an oblique fracture where it runs at an angle. The fracture line is angled across the axis of the bone. Then we have an open compound fracture. And just to give you a little piece, you don't have to memorize all of these. I just wanted that at least you have laid eyes on them at least once. The most important one is this one, open compound fracture, okay? This one, the bone is sticking through the skin. The problem here is infection. So this is the most serious. So the bone is exposed to air through a break in the skin and soft tissue injury. The number one priority is to prevent infection. If open fracture happens, you splint and cover it with a sterile dressing. Okay, then we have pathological fracture, which is just due to disease. Spiral fracture, it encircles the bone, and then transverse, it's straight across. Okay, so that is it for today. For homework, please make sure you have read all of Module 6, GI, that you study what we have learned about cirrhosis. Cirrhosis is the most important disorder for GI. So read the study guide, review the recording about it, and then for homework, go ahead and read all of Module 7. It's very short, and then review what we've learned so far so that when we come back next Friday, we can finish off strong and do some questions. Okay? The most important aspect of musculoskeletal is safety, and we're going to learn about that with the 6 P's. Okay? All right, guys. Well, you have done wonderful. Thank you so much for another wonderful class. God bless you. I know you all will pass the NCLEX, and I cannot wait to see you next week. Thank you.